Welcome everybody to the NephroWorldCup. We are from Spain. Go, go Spain. So here it is a pleasure for me to introducing Beatriz Fernandez. Hello, Beatriz.
Hello. Thank you for inviting me. This is an amazing NephroWorldCup.
We are presenting a work, a really nice work that was published in JSON, that it was performed by Dr. Gorriz and Dr. Apuchades. And it is entitled Albuminuria Lowering Effect of Dapagliflozin, Eplerenone, and their combination in patients with chronic kidney disease, a randomized crossover clinical trial. So, what's chronic kidney disease? We thought that the pandemic of now, it was COVID-19, but it is not true. Our new pandemic is chronic kidney disease, and around 850 million of people is suffering of chronic kidney disease. And we have very few clinical trials focused in this kind of patients. And it is a pleasure for us to introduce one clinical trial where Spain participated with a lot of patients. So what's my worst nightmare? And I suppose that for you also is a worst nightmare, Beatriz. My worst nightmare is not Freddy Krueger. Forget about it. My worst nightmare in my life is being a patient under dialysis program. So we need to delay the progression of chronic kidney disease. What is the goal of the nephrologists and people involved in chronic kidney disease? Our goal is to stop the progression. Why? Because we do not know. Can you imagine going 3 times weekly to a dialysis center and be connected to a dialysis machine? So no, never. I don't want this for me, for myself, and for any of my friends, including friends from another country, because we're fighting against, we are fighting in this World Cup, but we want the same for our patients. So we want to stop CKD progression in our patients with chronic kidney disease. How is CKD defined? Actually, Beatriz already published this and refreshed us the definition of chronic kidney disease. And chronic kidney disease is a patient with estimated glomerular filtration rate lower than 60 milliliters per minute, or an urinary albumin creatinine ratio higher or equal to 30 milligrams per creatinine. And the problem nowadays is that not all of these patients have been identified. So there are a lot of patients with chronic kidney disease that we do not know, because we are not routinely testing. Nephrologists, yes, for sure, as you know, but not everybody is routinely testing albuminuria in our patients. So we think that this should be tested. And a part of that, when we have already the patients diagnosed, this is not stated in the medical history. We need awareness of chronic kidney disease. And we need awareness because now we have new therapies, we have new treatments. So we were really sad, and for more than 20 years, we only had renin-angiotensin system blockade to delay the progression of our patients with chronic kidney disease. So the nephrologists were the ones crying in the corridors because our patients were ending in dialysis or dying from heart attack, stroke. So what's happening in 20 years, in the last years? Are we more happy? Beatriz, are we more happy in the last years?
We are very happy in the last years.
For sure.
Actually,
so in the last years, we had the opportunity of new drugs, SGLT2 inhibitors, that it was demonstrated in 2016 and 2017 that they can delay the progression of chronic kidney disease, first time after the blockade of the renin-angiotensin system. And GLP-1 agonist receptors that they demonstrate till now decrease proteinuria and albuminuria. Let's see the new studies that are currently ongoing. And in 2019, the endothelin antagonist and DPP-4 demonstrate decreased proteinuria and atrasentan delay the progression of chronic kidney disease. And what happened in last 2 years ago, finerenone demonstrated to decrease albuminuria and the progression of chronic kidney disease. So we are happy and proud because we now have new drugs for treating our patients. We should not be jealous now with the cardiologists that they have a lot of treatments for the patients with heart failure. Now we have our tools that we now need to use and have to use properly. Your turn.
So it's my time. So now we know there's a lot of things for us in nephrology. So in 2022, finerenone started using a secondary analysis on Figaro and Fidelio. And in this design, they saw that predominantly people with SGLT2 inhibitors could use finerenone and they were going to get better. And this finerenone was going to get better in terms of decreasing albuminuria. But when we are using finerenone with SGLT2 inhibitors, this is even better because we are going to decrease albuminuria and we are going to have better results in terms of potassium. So UACR, albuminuria, is going to decrease. So what Pepa told us before, it was like, well, you don't see, you don't know, but now we know that there are new therapies ongoing and that we have like a lot more things to do. So what is next? What is next? Okay, so we are going to talk about this test published in patients taking dapagliflozin or oxyrenone or the combination of both. So we know that finerenone is still ongoing. We don't have it right now, but we do have eplerenone and we do have dapagliflozin. So what's happening when we combine both therapies at the same time? And those were the inclusion criteria of this paper. Inclusion criteria, patients as we have normally in our regular clinical practice, urinary albumin creatinine ratio from 100 milligrams to 3.5 grams of albuminuria, eGFR more than 30 milliliters per minute and less than 90, that's it, our main population, serum potassium lower than 5 millimoles, which is okay, and stable doses of ACE inhibitors or ARBs for more than 4 weeks. And the exclusion criteria, type 1 diabetes, polycystic kidney disease, lupus nephritis, or some other nephritis that were associated with immunological diseases or malignancies. They also excluded people, women, pregnant women. So what happened with this study group? Okay, they did that in 46 patients. 30% of them were non-diabetic. That is very important because most of the other studies being performed in diabetic population, they had a lot of quite nice number of non-diabetic patients. And what did they find? They found that there were higher decrease of urinary albumin creatinine ratio when they were using dapagliflozin plus eplerenone. As you can see, dapagliflozin was quite okay. Eplerenone was quite okay. Wow, this is moving very fast. That's nephrology. And when we were using both at the same time, that was much better. And what happened with the potassium? So we are very, very aware of that because when we are using eplerenone or spironolactone, things with potassium are always a challenge. So what happened was that dapagliflozin didn't increase potassium, eplerenone increased potassium quite a little bit more. And when we were treating patients with dapagliflozin plus eplerenone, they decreased potassium. So if you use both drugs at the same time, you can have a better result in albuminuria with lower secondary effects like potassium. So this is the NephroWorldCup winning action. Use the best combination ever, the best combination we already have, and treat your patients with drugs that decrease albuminuria, decrease congestive heart failure, have better results in terms of potassium. So we think this is a winning combination. We think this is a winning paper, and we think this is a Spanish team that's going to be the best. Thank you, everyone, for listening to us, and vote for Spain. You won't regret.
Vote for us.